Thank you very much. It's an honor to be here today. I'm going to switch things a little bit since I'm a lefty. Holly came to me about a year ago and asked if I'd be on the planning committee, and somehow this morphed into me being up here speaking. So I'm not exactly sure how this happened, but here we are. I'm not going to talk about pharmaceuticals. I don't have any industry relationships to declare, but I do have one disclosure to make. All my speaking engagements in the last 4 to 5 years have been to funders and potentially anybody else who would listen to me talk about this idea for a small pediatric clinic. And so I want to apologize in advance if I slip up and ask you all for money, because that's what I usually do. So why am I in the lineup this morning? I'm not an expert, I'm not a researcher. I'm not bristling with a ton of statistics for you today. In fact, you probably don't need to take notes at all. But I am a primary care pediatrician, and I feel like I'm kind of in remedial training mid-career. I've probably missed more ASD diagnosis than I've made. And my daily practice reminds me of how much I don't know and how much I need to learn. I'm here to share with you some of our experiences at HopeCentral in our neighborhood at the intersection of medical culture, family dynamics, and economic and emotional stress. I hope that by sharing a few of these experiences, I can encourage the primary providers in this group to carry on with the work and perhaps to try something new with families. I feel like the stage has been set incredibly well by Catherine and Maureen for what I'm going to be talking about. They've given you kind of the background, and we're really operating in a neighborhood where we see exactly the type of kids that they're talking about. So who are we at HopeCentral? HopeCentral is a pediatric and behavioral health clinic located in Southeast Seattle. We launched in March of 2014 with an all-volunteer provider staff with a mission to share the love of Christ by meeting the physical, emotional, and spiritual needs of the Rainier Valley through an affordable primary care medical home. We provide evidence-based pediatric primary care and offer it to all families regardless of income or background. We are incorporated as a nonprofit, and our goal is to establish a sustainable practice that reserves 50% of its patient capacity for children who have subsidized insurance. We seek to foster a just and healthy community where families from diverse backgrounds come together around shared health needs. And we have designed our practice with 3 core distinctives, which are listed on the slide. One is longer appointment times. Our minimum appointment length is 30 minutes. Our initial evaluation is usually about an hour. Enhanced physician access. We take all of our own phone calls. We don't use any nurse triage system, and we pride ourselves on being accessible to parents. And the third is integrated behavioral health, which is one of our learning objectives today, and we'll come back to that as we go through our discussion. So where are we located? We are in the south part of the Seattle area. We're touted as one of the most diverse zip codes in the area, 98118. The neighborhood is known as Rainier Valley. According to the census, approximately 65% of the households in our neighborhood speak a language other than English at home. And the difference in the number of languages is incredible. Some people have said up to 100 dialects of languages, but at our clinic, we actually are most often calling translators for Russian, Vietnamese, Spanish, Somali, Tigrinya, and Amharic. This ethnic diversity, though, also comes with significant economic diversity and significant healthcare disparities. One of the things is we have much higher rates of childhood asthma and hospitalizations than other areas of the city. Our teen pregnancy rate is almost 6 times the teen pregnancy rate in other more affluent neighborhoods. And the statistics around mental health are also pretty bleak. In our neighborhood, children have higher rates of depression and physical abuse than the district-wide and statewide averages for same-aged peers. And these disparities accumulate into adulthood, and by the time you're looking at the adult population in our neighborhood, their life expectancy is actually almost 10% smaller or shorter than other neighborhoods in Seattle. So how did we end up taking care of kids with autism? This is kind of an interesting story. We opened expecting to take care of children with a history of trauma, recognizing that trauma happens in all strata of society, but disproportionately affects families with low incomes. Within a few months of opening, though, we realized that families of children with developmental delays were preferentially seeking us out. We found ourselves in a hole in the healthcare fabric that we didn't realize existed. As we cared for more families in transition, we also uncovered developmental delays, complex behavioral issues, and suspected autism. Local families with children on the autism spectrum started to come to us to check us out, looking for care close to home and excited about the integrated behavioral health. Within a few months, 30% of our patient panel carried a diagnosis of ASD, and we decided we needed to do something proactively to understand these kids and provide better care. We talked to the Seattle Children's Autism Center, who also told us that 30% of their year-long wait list lived in our neighborhood. Then I spoke to Arzu Farrow, and she mentioned that the schools in our cluster had the lowest referral rate for autism evaluation of any cluster in the Seattle School District. These conversations led to a lot of staff soul-searching. How do we preserve our desire to be a primary care clinic that is accessible to all members of the community, but also fulfill our core value of being small and nimble and able to respond to the felt needs of the community? Finally, our psychologist contacted Seattle Children's Autism Center again, and we got on the schedule for training to become an Autism Center of Excellence, which we did. We completed that training in March of 2015, and so now we are able to do autism diagnoses for children on Medicaid and do the ABA therapy referrals for that. So this is where we come back to our distinctives. As we began to walk out these three elements of practice, we quickly bumped up against underlying health disparities, those particular to our neighborhood, but also those that echoed widespread disparities in our country. What was our model that what in our model attracted families and made them willing to take a chance on us? I think the first thing was location. Location. We were in the neighborhood. People could walk to see us. They didn't have to load their kids, who tended to run away, into a car and park in a parking lot and walk to the clinic. They could go out their front door and walk a couple of blocks and come to see us. Families in the shelter were in the ground floor of the Union Gospel Mission shelter, and the families who lived in the shelter could just walk downstairs, walk 2 doors down, and come to see us. We also had this longer appointment times and the enhanced physician access. We made these initially a priority in order to leave space for relationship and for dignity. Our physicians really value having that relationship with parents, even in the off hours. And what this has meant for us is that we hear and treasure people's stories. Joe Sherman, who's here today, is one of our staff, and he's particularly adept at opening space at the first appointment for parents to share where they've been and how they came to us, their refugee journeys, their hopes and concerns for their children. I have found myself needing to learn how to hear and be present for very difficult stories for families in transition, and to learn how to be present for the tears and the self-doubt and the guilt that often emerge as parents tell their stories. Nighttime advice calls sometimes feel more like coaching sessions or parenting affirmations for mothers who are in shelter and don't have access to their usual communities of support. Families of children with ASD bring a whole nother layer of complexity to these interactions, and the longer appointment times allow us to develop rapport with the child and tailor our rhythm to hopefully accommodate the child better. Inadvertently, we've set up a rhythm of practice that answers one of the primary unmet needs expressed by families of children with ASD: more time with their physician. So what else are families looking for in a primary care medical home? Just like everyone else, they're looking for well checks and illness care. They're also looking for help with chronic medical problems. Families of children with autism spectrum disorder, however, are also looking for more intensive support for some other issues: management of sleep dysfunction, toileting, feeding, tantrums, self-harm. These are all complex and very often disruptive issues for families in their everyday life. They're also looking for more support for comorbid conditions such as anxiety, ADHD, and intellectual disability. 70% of kids who are on the autism spectrum have some sort of comorbid condition. The last one is care coordination. You saw the slide that Dr. Zuckerman showed of how many places people have to go to get services for their kids. It's incredibly time consuming. Some parents spend as much as 10 hours a week doing this. and it often affects their ability to work, or affects their ability to keep a job. So it's huge issues. So items 1 and 2 on this list are totally in the primary care wheelhouse. This is what we are trained to do as pediatricians. We can do this well. 3 and 4, most pediatricians are not as confident with. And some research suggests that even the confident ones, parents find not as adept as they think they are. But the care coordination is really difficult. It's time-consuming, which families already know, and it's unreimbursed in our current medical system. And there's a steep learning curve to be familiar with the resources that are available in a community. And so what does this work out to for families with children with special health care needs? Less than half of children with special health care needs find themselves receiving primary care in a medical home that includes things like family-centered care, comprehensive care, care coordination, and accessible services. Children with autism are even less likely than children with other special health care needs to receive care in a primary care medical home. So this is one of the first disparities that we found, just as people came flooding to our door. We're like, oh wow, this is a setup that you all really want and need. Research also shows that investing in these elements of care coordination and enhanced behavioral care can reap incredible rewards. Families of children with autism spectrum disorder in a primary care medical home are 4 times more likely to report that their coordination needs are met. They also report decreased family stress, improved quality of life, and decreased financial impact of obtaining care. So how do we handle, going back to the slide before, how do we handle number 3 and number 4 at HopeCentral? This is my favorite aspect of our practice, which is that we have a child psychologist in-house, and we do visits together. So anytime a child comes to see me as their primary care pediatrician, and brings up one of these issues, I can say, just a second, let me go get our psychologist. And we sit down together, we hear the story of what's going on, and we start to troubleshoot what can be done about it. How do we manage these behaviors at home? There are a number of advantages of having this care on-site and completely coordinated with the medical care. One is that it focuses on assessment, identification, and short interventions that are aimed at improving a child's level of functioning. 2, it allows a more preventative approach to psychological care, recognizing and addressing symptoms often before they meet the criteria for an official diagnosis. This is a huge issue for kids on Medicaid because you have to meet a threshold to be able to go to a regional mental health care community setting. And so if we are starting to see symptoms and we think we can head it off and we can start it in the primary care setting, we may be able to keep them out of the regional mental health center. Integrated behavioral health has also been shown to be cost-effective and reduce the stigma of seeking mental health care. It's a little distressing, but remarkably few patients who receive a referral to mental health care from a primary care setting ever go through with that referral. 40% of children identified with psychiatric diagnoses in primary care never receive care in any setting. So I think this is the aspect of our practice that was perhaps the most attractive to families of children with autism or other developmental disabilities. We have this expert on site in our psychologist, and then we have this ability to take a concern and do further assessment. The other thing for us as pediatricians is we can do more in-depth developmental assessment at the various well-child checks prior to the 2 years. So we are able to do things like both the ASQ and the MCHAT at 18 and 24 months, which is great. So I'm going to share a story with you that I think exemplifies not only initial barriers and some reasons why some of our patients have very late diagnoses of ASD, but also some of the systemic issues that we face in terms of treating and taking care of families. The patient's mother has given us permission to share the story, but the details have been changed. So Sarah and Deborah first came to HopeCentral shortly after arriving in Seattle, after fleeing domestic violence in another state. Living at a local shelter, Deborah struggled to control her daughter's behavior. At age 6, Sarah had a short attention span, requiring constant supervision during daily activities. She used few words, usually no, and often ran away from her mother in public places. We started her on some medication for her attention and impulsivity issues, and we began to see Sarah every 2 weeks. Due to her resistance to shots, she was behind on vaccines, but our behavioral health providers helped calm her and reassure her using bubble blowing, among other techniques. And we were able to complete her vaccines. We then began a formal evaluation for autism. After the first session with our psychologist, Deborah called Dr. Jones, the pediatrician, with an unusual question. She wanted to know if he trusted her. The structured interview portion of the autism evaluation had put Deborah on edge. She wondered why questions were being asked of her that had already been covered in previous conversations. What was the real purpose of this evaluation? Didn't the providers believe what she was saying? Hadn't they been listening? In the past, Deborah had simply left clinics when she had hard experiences. She had been frustrated and felt belittled in the past as she sought care for her own ADHD. She had also felt judged and blamed for a child's difficult behavior. This time, however, she had built enough trust with Dr. Jones to bring her concerns directly to him. Over the course of 2 phone conversations and an in-person visit, he reassured her that the standardized format and the repetitive questions were essential to the diagnostic process and not indicative of a lack of trust in her. So with Deborah's support secured, we could resume the evaluation. In the first observational test, however, Sarah resisted participation, avoiding the prescribed activities and refusing to engage with our psychologist, Dr. Braisted. In response, our behavioral health team had to go back and develop a social story, which is a detailed series of pictures that shows each step of the test. After reviewing the social story multiple times at home, Sarah was able to cooperate with the testing and complete the assessment, leading to a solid diagnosis of autism spectrum disorder. The last 6 months with this family have been spent getting them into ABA therapy, for which they're still on a partial wait list. She's gotten an IEP through her school. They've moved into transitional housing, and we've actually been able to advocate for that transitional housing to be closer to their spot for ABA therapy, hopefully smoothing the future attendance at therapy for the family. So Sarah and Deborah's story really illustrates the many factors that can conspire to prevent timely and accurate diagnosis and treatment of ASD. Family disruption, economic hardship, medical culture, provider bias, parental trauma. As a staff, we learned valuable lessons early on in our operations. One is that relationships take a long time to build. 2, trust can overcome a lot of barriers. And 3, early experience in the healthcare setting can affect families' reactions and expectations, and sometimes are the hardest things to overcome. The other thing about Sarah and Deborah's story is that it's a microcosm of broader disparities for families of color and those living on the economic margins. We're fortunate that in Washington State, most children are eligible for subsidized insurance, but insurance doesn't guarantee appropriate care. We talked a little bit about the bias of diagnoses for African Americans. And they're 5 times more likely to be misdiagnosed with a conduct disorder and 2.5 times more likely to be misdiagnosed with adjustment disorder than Caucasians. The last bullet on this slide is probably the most heartbreaking to me and feels like the intersection of where we operate as a clinic and some of the diagnostic challenges that we've had to face. Many of you may be familiar with studies looking at adverse childhood events, or ACEs. It's a litany of 9 traumas that can be experienced in childhood. And the accumulation of these traumas actually is a risk factor for development of adult chronic diseases. The few studies have looked at this in kids with autism, and 34% of children with autism report multiple adverse childhood events. That's 4 or more, compared to 24% of the general population without autism. Now, 24% in a general population of kids is awful to begin with, but 34% is incredible. Trauma disproportionately affects children with autism, even when they control for age, race, sex, family structure, and poverty. I mean, this is something that's particular to autism, and it goes beyond bullying. Long-term, this level of trauma increases the risk of the most common health problems in adulthood and increases the cost of caring for people through their lifespan. And for us, we see this as the overlay of trauma, teasing out the diagnosis of autism much harder. Severe anxiety or intense early neglect may look a lot like autism, and it's really hard as we're going through an evaluation to figure out what is contributing to these behaviors in kids. You can see in a very anxious kid very stereotyped behaviors. You can see rigid routines in OCD. You can see apparently incongruent reactions in social situations when kids have been abandoned or have had to move through many foster care situations. You can see prolonged temper tantrums. You can see food eating issues or feeding issues in kids who have had food insecurity. And you also can see profound language acquisition problems in children who have had early neglect. These are all things that are also factors with autism, and sometimes it's really hard to tell what's causing it. So if you take away a few things from what I've shared today, I think one is I'm a believer in integrated behavioral health. This has been a great asset to our clinic, and I think should be one of the core elements in caring for kids with autism. The second is that trust takes time, but it's worth the time. Right now, our medical reimbursement system isn't set up to value this kind of time, but it's worth it. And the third is that hope can be rebuilt. One of the things that's been wonderful about taking care of some of these families is as we've stayed with them for a year or more, we've seen them come from a place of feeling guilty and awful about their children to feeling hopeful and understanding what's going on with their child better and feeling like someone is in their court. So I'm hopeful that we can help other people kind of move down this road in community clinics to serve this population of kids better. This is a picture that we have in our, a painting that we have in the waiting room of our office by Mary Ann Nagy, who's a local artist here in Seattle. And it kind of encapsulates some of the things that we try to do in the clinic, which is to recreate hope and create a safe place within the city for parents to bring up their kids. So thank you very much for listening. I appreciate it.